So hello everyone, my name is Sarah Eisinga and I'm the Manager of Patient Programs, Research and Advocacy here at Lymphoma Canada. And I'm pleased to welcome all of you today to today's conference session on Waldenstrom Macroglobulinemia. We appreciate those that are able to attend live today to learn more about the disease-specific biology and diagnosis of WM. This presentation will also highlight novel research and treatment options that are accessible to Canadian lymphoma patients. Now, before I introduce today's speaker, I'd like to provide some guidance about the Zoom software for this session. This virtual software does not allow you to share your video or microphone. So if you have any questions, please save it for the non-Hodgkin's lymphoma Q&A session following this presentation. This is where you can ask your questions to the presenter live. And now I would like to introduce and welcome you our speaker, Dr. Christine Chen. Dr. Christine Chen is the Medical Director of the Autologous Stem Cell Transplant Program and Clinical Lead for the Immune Effector Cell Therapy Program at Princess Margaret Cancer Centre, a part of the University Health Network in Toronto. She is appointed as Associate Professor at the University of Toronto and is a member of the Clinical Research Group for Multiple Myeloma and related mature B-cell disorders, including chronic lymphocytic leukemia and Waldenstrom's macroglobulinemia. Dr. Chen's interests include the evaluation of new agents in the treatment of Waldenstrom's and multiple myeloma. We thank you very much for joining us today, and now I'll turn over the presentation to you, Dr. Chen. Thank you.
Thanks very much, Sarah. I'm very honored to be here to present on Waldenstrom's macroglobulinemia. This is a disorder that's close to my heart, and I know many of you have reached out to me in the past about this disease. So thanks again, and I will proceed. And this is a list of what I'll cover in this talk. I'll talk about clinical features of Waldenstrom's, how to diagnose WM, when to start treatment, and first line as well as second line treatments and beyond. And then there are special clinical situations that demand specific therapy, which I'll touch upon at the end. So what is Waldenstrom's macroglobulinemia? Well, this fellow here is a Swedish physician named Jan Waldenstrom, who in 1944 described two patients that he noted that had nasal bleeding and anemia, and found a giant molecule in the blood, which we know today is the IgM protein. These two patients had Waldenstrom's macroglobulinemia. The incidence of Waldenstrom's, we know, is uncommon. It's 1 to 3 per million, and it only accounts for 1 to 2% of blood cancers. And therefore, it is particularly important to have groups like Lymphoma Canada to bring all patients and families together. The diagnosis of Waldenstrom's is largely based on having a morphologic picture, or rather under the microscope, you can see that this is a form of lymphoma, which we refer to as lymphoplasmacytic. The term refers to the types of cells that we see. Sometimes they look a little bit more like lymphocytes on the left here. Other times the cells look more like plasma cells that we can see much more akin to a disease called myeloma. And then sometimes the cells on the panel on the right look kind of like a hybrid of the two types, lymphocytes and plasma cells. And as a result, just looking under the microscope at tissue from a bone marrow or lymph node from a patient with Waldenstrom's is often difficult to make the diagnosis without mixing it up with other types of lymphomas or myeloma. The other prerequisite for the diagnosis of Waldenstrom's is the presence of a monoclonal, which means the IgM protein arrives from a single clone, so monoclonal IgM protein. And that's depicted here. The IgM protein is a really large protein. It's kind of made up of 5 different smaller antibodies. And as a result of its large size, it can create sludging in the blood, which we'll talk about shortly. So what else can this protein do? Well, it can cause problems, as mentioned, sludging in the blood, which we refer to as hyperviscosity. The IgM circulating around can also in cold parts of your body, like the tip of your nose or your fingertips, can precipitate out and cause blockage of blood vessels. We refer to that as cryoglobulins. The IgM can interfere with the coagulation factors and lead to bleeding. The IgM can also, besides just circulating, can deposit in tissues like the kidneys, skin, and the gut. That is uncommon, but an even more rare complication is that the part of the IgM protein can deposit in a specific fibrillar kind of pattern, and that's referred to as amyloidosis. I'll talk a bit more about specific management of that later. And then the IgM is an antibody, so it can also land on different tissues and cause immune-mediated problems. One of the issues that we see relatively frequently as Waldenstrom is neuropathy, where the IgM protein lands on the sheaths of the nerves and causes damage. And cold agglutinin disease is when the IgM lands on red blood cells and makes them break down or hemolyze. So you can imagine how clinically this can be a very diverse type of disease, and unless you're very aware of Waldenstrom's, you may miss it with just some of these early clinical symptoms. So we are very fortunate that we now have a diagnostic test that is able to identify 97% of patients with Waldenstrom's. And you've all heard of the MYD88 mutation, MYD88, is actually a protein, and I'll show you on the image on the left. It's a protein that's inside the cell. So this is the edge of a cell. We're kind of cutting it in half so you can see the inside. And that normally, in response to foreign bodies, bacteria, or inflammation, the MYD88 is triggered to form a complex here. And ultimately that triggers this whole pathway leading to activation of division of that cell. So that controls proliferation and growth of this cell. So let's say this is a cancer cell. In Waldenstrom's, the cancer cell doesn't require any triggering of the MYD88, so it's a continuous activation. And so this cell continues to grow and proliferate, which is what makes it cancerous. And so this is the mutation seen in most Waldenstrom's patients and has been very helpful as a diagnostic test to help distinguish it from the other types of slow-growing lymphomas, as well as myeloma. But there are a few patients with Waldenstrom's who actually don't have the MYD88 mutation. And it may be just because your testing site doesn't look for the many different MYD88 variations. So it's always helpful to ask your physician whether your lab has the ability to test for the other less common variants, but that would tell you that you do have MYD88. And why is that important? Because it may, if you don't have MYD88, you might actually have other diagnoses. As I talked about, a third of patients who don't have MYD88 end up actually having myeloma or other types of lymphoma. And if you don't have MYD88, but you look like you have Waldenstrom's otherwise, you may respond differently to certain treatments, particularly our novel therapies like ibrutinib. So it's important to test carefully for MYD88, and we are recommending that all patients undergo this at time of diagnosis. We know that in a third of patients, and mostly these are patients who also have MYD88 mutation, that a third of these patients also have CXCR4 mutation. And this is just a picture of the gene, of the molecule rather, for CXCR4, and there's a particular region that is mutated in Waldenstrom's. And why is this important? Well, again, therapeutically, these patients do not respond as rapidly or as long to drugs like ibrutinib. So it is useful to help select for therapies. Many centers do not routinely test for CXCR4 mutations, as there are many of them, and it's a little bit of a complicated test. So once we've made the diagnosis of Waldenstrom's, how do we decide when people should be treated, or should all patients be treated? Well, there are patients who have no symptoms. I went through already the complications one can see related to the IgM protein. Patients can also, I should note, have just systemic symptoms such as fevers, weight loss, sweating, and they may have enlarged lymph nodes and organs like spleen or liver. If you don't have any of those complications, you have what we call smoldering Waldenstrom's. And it's important still to follow patients who don't have symptoms, because they do have a risk of progressing to active disease, more so in the first few years. So you can see here, this is just a curve showing that in the first 3 years, 40% of patients will have progressed to active disease. So that's about 12% per year. But then it starts to flatten out so that eventually, when you get beyond 5, 6 years, the rate of progression every year is only about 2%. And overall, though, most patients, 70% of people, will eventually need treatment because of symptoms. And so this is important because it means that when you're first diagnosed, even if you have no symptoms, you should be followed a little more closely, because your risk of progressing to become active with new symptoms is higher than later. If you've kind of gone beyond 5 years and nothing has happened, your disease is stable, then your physician can start to back off a little bit, and some patients are only seen on a yearly basis. So can we predict when people will need treatment? We're not very good at this yet, because many people, as I mentioned, will eventually need treatment, but we don't always know when it will happen. So this is kind of an interesting app. It's a website, actually, that you can go on to. And the key is really that they identify 4 features, and there are many studies that have identified others, but 4 main features that kind of help us define who might progress earlier. So the amount of involvement of your bone marrow, the amount of protein. The higher your IgM level, the more at risk you are for becoming active. Beta-2 microglobulin is just a molecule in your blood that actually goes up with certain tumors, so it is also predictive. And albumin goes low when people have more advanced disease. So these are, if you mix all these 4 together, you can go on this website and add in your numbers, and you can get a general estimate for when you may expect to progress. It's not an exact science, but some patients are very keen to have some estimate, and this may help appease some of your questions. But most of the time, we need to just follow patients and watch out for any of these clinical or lab factors that may indicate that it's time to start treatment. So I've already talked about symptoms like fevers, sweats, weight loss, or just profound fatigue, hyperviscosity, or the thickening of the blood based on a high IgM level, the enlarged organs or lymph nodes or other tissue infiltration. Rarely we'll have like people with skin lesions, or sometimes the kidneys are enlarged from infiltration. And of course, I mentioned the peripheral neuropathy. Those are clinical factors. Lab factors may include any of these here. And I just want to point out that anemia and low platelets are frequently seen in Waldenstrom's as an indication to start treatment, primarily the anemia. But it is important to note that a lot of patients with Waldenstrom's will have concurrent iron deficiency, and it is related to dysregulation of iron from the that's due to the presence of the paraprotein, the IgM protein. So it is useful, if all you have is a low hemoglobin as an indication to start treatment, to be looked for iron deficiency, because very occasionally one can just replace the iron and your hemoglobin will come up, and we can avert the need for any more therapy at that point. The key here is that smoldering Waldenstrom's patients need regular follow-up to monitor for any of these factors that would indicate that it's time to start treatment. And so when it's time to start treatment, what choices do we have? And so I've lumped what I'll talk about into 3 groups. One is traditional chemotherapies, which still have a role, novel targeted therapies, and then just a little bit about some of the newer therapies that are just around the horizon. So let's start with traditional chemotherapy. So one of our key combinations we use is BR, also referred to as bendamustine and rituximab. So 2 different drugs. Bendamustine is a drug that we've used for decades in various types of lymphoma. It's intravenous. It has a typical chemotherapy type side effects like low blood counts, and as a result, you're prone to infections. Sometimes it can cause a rash around the injection site, but it is generally relatively well tolerated. Rituximab, many of you have heard about before, or maybe have already received. It's now been around for almost 20 years. It's an antibody to CD20. CD20, as you can see on this image on the right, this being the Waldenstrom's B cell. CD20 is a B cell marker, so it's a marker on the surface of the cells. And Rituxan, which is indicated by this Y figure, binds to that CD20, and then it induces your immune system to kill this cell. So it pulls in other immune cells like NK cells and macrophages, and it causes the death of this cancer cell. So we use it a lot in various types of B cell lymphomas. It is also an IV infusion, though it can also now be given subcutaneously as an injection into the skin. And one of the main side effects is it causes infusion reactions, and it may also predispose to infections, as do most therapies. So one of our primary treatments of use in Canada, certainly, and globally, is the combination of BR. These are both given over 2 days and then repeated every 4 weeks for a total of 6 cycles. So it's finite course treatment. You're finished in 6 months. One of the unusual features of rituximab use in Waldenstrom's, and is worth mentioning here, is that the IgM level can actually flare and go up with rituximab when you start it. And this is really, this is the first indication of this from an early study from Steve Treon at Dana-Farber. And all these different lines represent the different patients who have varying levels of IgM at the start. And you can see that many of them, when they started rituximab, had their IgM levels go up. And I point out this particular patient who started off quite high and then went even higher and ended up developing hyperviscosity at that point, needed to be urgently plasmapheresed, or which is where you take the protein off. So it's something to watch for. We're pretty familiar with this now. It's an idiosyncrasy of Waldenstrom's with rituximab. There are different approaches to managing the rituximab. You can hold it for the first 1 or 2 cycles and just give the bendamustine, wait until the IgM starts to fall before you introduce the rituximab. Sometimes we may plasmapherese or remove the level, the IgM temporarily before starting therapy so that the start point is lower. Sometimes we'll still proceed, but we'll follow the IgM closely, like every week. And if we start to see something like this where it climbs, then we'll plasmapherese when it flares. So there are various approaches that your medical team can take. So why do we use BR? Well, this was largely based on now a fairly old trial from 10 years ago, where patients with various types of slow-growing lymphoma, including a subgroup of Waldenstrom's patients, were treated with either BR or compared to R-CHOP, which is another common lymphoma regimen that we use often for aggressive lymphoma. So it is considered a bit of a more intensive regimen. And they essentially showed that this is a very effective regimen, BR, and appeared to be superior to the R-CHOP, which is what we considered a more intensive regimen. And it led to fewer side effects than with R-CHOP. So this early study led us to use BR as our first-line standard of care in Canada. And so we've been doing so for about 10 years. And as with other types of slow-growing lymphoma, we used to follow up after the BR or whatever treatment used first. Once the patients have gotten into some kind of level of remission, we would then maintain them with rituximab given every 2 or 3 months for 2 years. And that is because with slow-growing lymphomas, we're not curing patients. We get the disease down, and the maintenance will prolong the duration that it will stay stable. So we used to do this routinely in Waldenstrom's patients until the MAINTAIN trial was presented a few years ago. And this was a study looking at maintenance just in Waldenstrom's patients. The previous study I showed you was a grab bag of lymphomas. There were only 41 patients with Waldenstrom's in it. And what we're seeing now is that there are more and more studies that are devoted just to Waldenstrom's. So we are getting a much clearer idea of how these different treatments work in Waldenstrom's as opposed to just generalizing it from other types of more common lymphomas. Anyways, back to this study, it compared the use of rituximab versus no maintenance in Waldenstrom's patients and really did not find any difference. What it did do was confirm that this BR, because most patients started off with BR and then went on the maintenance trial, that this is a very effective treatment and patients can often go 9-10 years before it starts to grow again. So we are not currently using maintenance rituximab in Waldenstrom's, although it may be still considered for patients who don't quite have a very good response to the initial BR. On this slide are a whole bunch of other chemotherapy combinations we can use. I'm not going to go through them all except to just point out that there are other options. Options that use a drug called bortezomib, which is again a targeted therapy, useful because it doesn't cause that IgM flare, so it might be good to use in people who have hyperviscosity where you don't want the IgM level to go any higher, and can be given in patients even with kidney failure, even on dialysis. There are other combinations with rituximab. The R-CHOP I mentioned before is more of a regular lymphoma, aggressive lymphoma therapy. Fludarabine is a drug that we've used for many years, not used very commonly now because it does cause low blood counts and suppresses your immune system. But it can be considered and is still very effective. And rarely we'll consider a stem cell transplant using your own stem cells. Again, we only use this largely for patients who have a concurrent complication referred to as amyloid. Again, I'll talk about that more later. But what you've all heard of recently is the use of BTK inhibitors or Bruton's tyrosine kinase inhibitors in Waldenstrom's. And it makes a lot of rational scientific sense to use these because MYD88, I showed you this before, is the molecule that's in the cell that forms this complex that then triggers cell growth. Well, in the process of MYD88 forming this complex, it also activates BTK. And so using inhibitors to BTK makes some sense here. And so ibrutinib is our first BTK inhibitor that was available for commercially. It's a oral capsule or tablet, so pretty easy to take. And when given by itself, it's just taken continuously, endlessly, as long as it's working. So we're sort of starting to treat patients more like they have a chronic illness, much like you have hypertension. You need to take a medication to control it. This was approved by Health Canada for the treatment specifically of Waldenstrom's as a single drug in 2016, and then in combination with rituximab in 2019, based on this pivotal INNOVATE trial. This was an international multi-center phase 3 trial. Phase 3 meaning there are two arms. One is the experimental arm, and the other is a standard of care arm. And we participated at our center in this trial. So it compared ibrutinib plus rituximab against just rituximab alone. And this is, I'll refer to progression-free survival over the next few slides. Not really, it just refers to the length of time you're alive without progressing with your Waldenstrom's. And you can see that ibrutinib does much better than just the rituximab. And at the most recent follow-up a couple of years ago, at 4 years on this study, most people are still responding. So this is taking continuous ibrutinib can be a very effective treatment. And you'll note, though, that this study used rituximab with it, but we've learned since from other diseases like CLL that you don't necessarily need the rituximab. This is a slide that I borrowed from Jorge Castillo from Dana-Farber, where he just shows a bit of the data with studies in Waldenstrom's using ibrutinib and rituximab. That's this study, and then the ibrutinib INNOVATE trial, which was also with rituximab. And then these two trials here, relapsed and frontline, were just monotherapy, ibrutinib alone. And without even looking at the numbers, you can see that most of them the numbers are kind of similar. The ORRs, overall response rates, are all sort of between 90 and 100%. The PFS, which as I mentioned earlier, is the progression-free survival, is all pretty similar also. So I think there's not a lot of compelling need to add the rituximab, and most of us just use ibrutinib alone. Adding rituximab does, however, lead to a more rapid response. So sometimes you can add it if someone has a lot of symptoms and you need to get a faster response. Or sometimes people use it by adding rituximab later if the response to ibrutinib alone doesn't seem as adequate. Ibrutinib, although a very excellent activity drug and also generally well tolerated, does have some side effects. About a quarter of patients get symptoms like diarrhea, achy joints, nausea. 10% will have high blood pressure. So when you're on a drug like this, you need to have your blood pressure checked regularly. Half of patients get easy bruising, and a small percent will have some major bleeding. This is because the ibrutinib can cause some platelet dysfunction. These are little cells that help you clot. And then what everyone talks about is the atrial fibrillation, which is a heart rhythm abnormality, more common in patients who already have heart issues. So if you already have some heart issues and you're starting ibrutinib, it's worth making sure you have a good screen for your predisposition to this arrhythmia. But only 10% of patients get low blood counts. I mentioned some of the low blood counts associated with other chemotherapies like fludarabine, et cetera. And so this is a pretty easy drug for patients who will start off already with, say, anemia or low platelets. But despite the fact that I mentioned all these side effects, but in general, ibrutinib is pretty well tolerated, but a quarter of patients do ultimately need a lower dose due to side effects, although they can continue to respond at a lower dose. But since ibrutinib may be given long-term, so I showed you some of the curves, the progression-free survival curves on the previous slide, patients can sit quietly with ibrutinib for 5, 6, 7 years until it's no longer working. So if you're using it this long, even minor side effects can affect your quality of life. And so we've seen in recent years the development of other BTK inhibitors. You will have heard of acalabrutinib and zanubrutinib, which are both much more specific for the BTK inhibition than inhibition of other molecules. So you can see this is ibrutinib here. These are just maps that show you how specific each drug is against the different types of kinases. We're trying to target Bruton's tyrosine kinase, but ibrutinib hits a whole bunch of other kinases that cause the side effects. And you can see that acalabrutinib and zanubrutinib are much tighter and don't have so many other effects on other kinases. So we anticipate that these types of drugs will work just as well as ibrutinib, but perhaps have less toxicity. And indeed, that is what we see. And I'm going to talk a bit more about zanubrutinib because it is Health Canada approved in Canada for Waldenstrom's now. Acalabrutinib, not yet, but is available compassionately as well. But zanubrutinib was shown in a trial specific to Waldenstrom's. It's called the ASPEN trial, to be just as good, maybe even better than ibrutinib when compared. So zanubrutinib is normally given twice daily, but can be given once a day, versus ibrutinib, which is once daily. Both of these were given ongoing, long-term until it wasn't working any longer. And these bar graphs on the left just show you that the top dark blue part is those patients who had a deeper response. The lighter blue are partial response. So any of the bluish, the two top bar colors are responders. But you can see with the zanubrutinib that deeper responses were achieved with zanubrutinib. And there essentially wasn't any difference between the two in terms of the duration that they work, so the progression-free survival. So zanubrutinib is certainly not inferior, maybe even a little bit better than ibrutinib. And we see on the next slide that it appears to have fewer side effects than ibrutinib. In terms of the usual things, the atrial fibrillation, the diarrhea, the bleeding, and the high blood pressure are all less with zanubrutinib. And there were fewer dose reductions and discontinuations of zanubrutinib versus ibrutinib. However, nothing is free here. So you can see, though, that the trade-off is that zanubrutinib does have an increased risk of causing low neutrophils. These are cells that are white cells that help prevent infections, primarily bacterial. Although it is encouraging to see that the rate of infections didn't seem to be higher. So it's something to watch for when using zanubrutinib, which, as I mentioned, is now Health Canada approved. So how do you decide between BR and the new BTK inhibitors? Because that's usually our decision is usually between these two types of therapies. Well, a lot will depend on individual features of patients, but also your preference. Some patients prefer to have treatment that might be a little harder, that needs IV, that needs you to come into hospital, but finishes in 6 months, and that's BR. In general, it's pretty economical too for a publicly funded healthcare system. BR also, I mentioned, patients who have the MYD88 or CXCR4 mutation tend not to respond as well or as fast to the BTK inhibitors, so we still prefer to use the old-fashioned chemo in those patients. BTK inhibitors, however, are extremely convenient. They're just pills, well tolerated, even in elderly or frail patients, and highly effective. And many patients don't mind taking a pill every day, much like they do to control their blood pressure. So choice must be personalized to each patient and their disease. So what's new and exciting? Well, we know that the BTK inhibitors like ibrutinib and zanubrutinib work very well, but eventually they generally stop working. And why is that? It's because here on the left, you can see this is a BTK molecule, and ibrutinib binds in this little pocket at this one site. It's called the cysteine 481. Eventually, patients can develop mutations at this site, as there are a couple other sites as well. And that means that ibrutinib can't bind so tightly anymore, and so will just fall off. And that's the main reason why patients no longer respond to ibrutinib. So there are new drugs called that are what we call non-covalent binding BTK inhibitors, Pirtobrutinib and Nemtabrutinib. They don't bind to the same site and may be effective even after ibrutinib failure. And these are very well tolerated drugs so far. They're both being used in clinical trial in Canada. And we're hoping to see more data from these trials shortly, and we fully anticipate there will be Health Canada approvals coming in the future. We also have heard about the efficacy of a drug called venetoclax in Waldenstrom's. I'm only selecting out a few drugs to talk about that we know are available in Canada. Venetoclax is not Health Canada approved for Waldenstrom's as of yet, but is widely available in other diseases like CLL. It's a BCL2 inhibitor. So BCL2 is a protein that leads to or inhibits the normal death of cells. And all cells grow and die. And that's, if you inhibit the death of cells, and they just continue to accumulate, and that can be the major cause of tumor development. So if you block BCL2, you're no longer inhibiting its inhibitory effect, and you can allow cells to die. So the venetoclax is effective in other diseases after failing ibrutinib. One of its major side effects is it can work so well that the cancer cells die quickly and release substances that can cause damage to, say, the kidneys. So there are precautions in starting venetoclax, but overall it's a pretty well-tolerated drug. It's oral. The responses are high in Waldenstrom's. This is from a phase 2 study just in Waldenstrom's. And so far, it looks like when you use it in the relapse setting, the effect can last for 2-3 years, maybe longer, and further investigations are happening now. The one caveat, or besides the tumor lysis I talked about, is you can get low neutrophil counts. I talked about that with zanubrutinib, in that it may predispose to infections. So sometimes you will need growth factor support with its use. So all to say, this is another option that, even though it's not approved in Waldenstrom's, can be available mostly at this time through your private drug insurance. I'm going to lastly talk just about some special situations. Waldenstrom's is quite unique in that it has presentations that are not commonly seen in other kinds of diseases. So I'll talk about these 4. So I've mentioned hyperviscosity already. This is when the level of IgM is so high that it causes sludging of the blood. And you can see here that it's so thick that it doesn't run down the side of the tube. And so when the blood is thick, the blood can't get to things like your brain, get headaches, blurred vision, confusion. It can block the blood going through your lungs and cause shortness of breath. So these are often kind of vague symptoms. Someone who feels there's headaches may not attribute it to their IgM levels. So you do need to always be aware of these side effects and bring them up with your doctor if they recur. When we see patients and we think they have hyperviscosity, we will test their blood for the viscous level, but it's not always very quick in returning that lab value. So one of the fastest ways is then we look at the back of the eye, because we know if your blood is thick, that the blood vessels can be engorged and they sometimes break. And we can see tiny blood vessels by using our ophthalmoscope and see them directly just sitting in clinic. So that is something your physician may do intermittently. With all my new Waldenstrom's patients, I have them all seen by an ophthalmologist so they can dilate the pupil and take a good look at baseline. What's the management here? Well, we need to get this protein down fast. So plasmapheresis is where we clean out the blood from the, we're using a machine like a dialysis machine, and that can bring it down quickly. But then you need to get onto some therapy so that the IgM level doesn't build up again. And we want to avoid using drugs like rituximab at the start, where we know it can worsen with an IgM flare. And this is just to show you that some of you may have had this performed. This is plasmapheresis, where we put an IV in one arm, and that where you would take the blood out, and then we put an IV in your other arm. And after we, the IV that takes the blood out will clean out the IgM protein, and then we'll return the rest of the blood back into your other arm. So another side effect we see relatively frequently in Waldenstrom's is peripheral neuropathy. About 20% of Waldenstrom's will actually have clinical symptoms at diagnosis, but probably the majority of patients will actually have some neuropathy if we specifically do nerve tests. The symptoms they commonly have are numbness or tingling, usually in the fingers, the toes. It can sometimes feel like burning. Rarely people are weak or trip and fall. Although 20% present at diagnosis, eventually up to half of patients can have some symptoms that develop during their lifetime. And there are many causes of why Waldenstrom's patients get this neuropathy, but one of the major ones is the IgM protein lands on the nerves, the coating of the nerves, and causes damage. And when you damage the coating of the nerves don't send their electrical signals normally. This is a really challenging complication to manage. We do sometimes do a trial of plasmapheresis to try to take off the IgM protein. That's not a long-term management, but it does sometimes tell us for sure whether the IgM protein is the cause of the neuropathy. Sometimes there are many other causes of neuropathy that may coexist with Waldenstrom's. So diabetics may get neuropathy. So we're not always sure if it's due to the IgM protein. So plasmapheresis, sometimes if we take it off the protein and people get immediately better, then we can at least identify cause and effect. Rituximab may be useful. And then there are anecdotal responses to steroids, fludarabine, the use of IVIG or immunoglobulin or antibody infusions. The goal is to eliminate the IgM protein as completely as possible and allow the nerves to regenerate. But as I mentioned, this treatment is challenging and therapies are not consistently effective. So we often need supportive therapies to help patients live with the symptoms. We use drugs like gabapentin, which help dampen the nerve irritation so that you don't feel the tingling and the burning. And other drugs listed here do the same. And it's helpful sometimes just to tell patients to do more exercise or use warm baths for their hands or feet. The circulation seems to help with the symptoms. And then Bing-Neel syndrome is it's a term that refers to any involvement of the brain or the central nervous system with Waldenstrom's. And I can show you down below that the pictures here of an MRI of brain can involve the brain itself, or it can involve the spinal cord. And you can see the white part means that the surrounding of the spinal cord is thickened. So there are many different presentations. So you can imagine if you had this in your spine, you might have weakness or tingling in your legs or problems with your bowel function or back pain. If you have something in your brain, you may have headaches, visual changes, and confusion, etc. So there are many different symptoms that we watch out for. This is a rare complication, but still something that one should be aware of. And luckily, many of our treatments can go into the brain and clear the disease there. In the past, there's a lot of our treatments we gave into the blood wouldn't cross over the barrier to the brain. But our newer drugs, including ibrutinib, can be very effective. And this is a report, again, from Steve Treon, that shows this lesion in the brain here that lights up on this PET scan. And you can see that with just taking a pill, ibrutinib, that lesion is gone. You can see that it's no longer lit up in that spot. So it can be very effective treatment. And then the last complication I just want to mention, because some of you may have heard of this, and I've mentioned it earlier, is amyloidosis. This is where the IgM, part of the IgM protein, the light chain, deposits in tissues and causes organ dysfunction. And it deposits in a particular fibrillar pattern that when you biopsy that tissue, you can see the fibrils. And this is under a special microscope. And this is under just regular biopsy. You do a special stain and you can see this kind of greenish color. So this is how we diagnose amyloid in conjunction with Waldenstrom's. It can affect critical tissues like the heart and the kidneys. So it is really concerning when it involves the heart, because the heart does not pump as well and can cause electrical abnormalities as well. Diagnosis always requires a tissue biopsy of a lump somewhere, an organ, bone marrow, something. You have to stain something to look for the amyloid deposition. And then the goal is to eliminate the M protein. In most Waldenstrom's patients who need treatment, our goal often is to decrease the protein. We not necessarily eliminate the protein. People can live with a certain level as long as it's stable. But in amyloid and neuropathy, our goal is to try to get it to zero if possible. And that can be done with various treatments that are highly effective in amyloid. I won't talk much about that, but it is one of the few indications where we may still consider doing a stem cell transplant for Waldenstrom's. So that was a whirlwind through the clinical, diagnostic, and lab spectrum of Waldenstrom's macroglobulinemia. And I hope I've been able to relate to you that Waldenstrom's is now emerging as a unique disease. So we know how to diagnose it. We have very specific tests, the MID88 test for it. And we're starting to understand management specific to it, because there are more and more trials that just focus on Waldenstrom's patients and the idiosyncrasies of management. So it is always important that Waldenstrom's, because it has many unique clinical features, we often do need to modify our therapies to account for the those features, such as the IgM flare or the neuropathy. So I'm hoping this presentation gave you a little bit of an insight into some of the new advances in Waldenstrom's. It's a very exciting area. So thank you very much.
Awesome. Thank you, Dr. Chen, for your excellent presentation. We appreciate your excellent review of this lymphoma subtype, detailing the treatment options for patients with WM for both frontline and refractory settings, and highlighting newer treatment options that are available for Canadians. I would now like to direct our audience to attend a breakout session after this presentation, where you can have your answers questioned and live. Thank you.
Thank you.